Let's cause the shoulder joint anterior dislocation to the model partner. The shoulder joint is corrected for abduction and extension. The proximal end of the humerus collides with the upper rim of the glenoid cavity and the shoulder peak, and the humeral head is pushed out by the lever principle. When the proximal end of the humerus collides with the shoulder peak due to the shoulder rolling progress, it becomes the fulcrum and the force which pushes forward to the caput of bone depending on the lever principle. Although it dislocates the caput of bone by its power, it does not come off horizontally because there is a coracoid process on the front. Therefore, the head will dislocate forward and downward. At this time, the head rubs the glenoid cavity and bunker to damage, which is joint lesion damage, may occur. Also, the head side may be pressed against the glenoid fossa, resulting in Hill-Sachs damage, which is a compression fracture. The head is dislocated forward and downward, and due to resilient fixation, the shoulder joint becomes abduction and internal rotation, and the patient supports with the hand of the healthy side. As a result, the head will move upwards to draw a V shape, fit in the Morishoji's fossa, and become dislocation of the shoulder joint. Observe the stereotaxic dislocation of the shoulder joint anterior dislocation. The model is sitting. First we will observe from the front. You can see that the caput of bone shifts inferior inward and moves under the coracoid process. You can see that the upper arm is slightly outer dislocation. Next, observe from the side. You can see that the caput of bone has moved out of the glenoid cavity and is moving forwards and downwards. You can see that the upper arm is inner turning. Let's consider the repair path from dislocation. What kind of operation is necessary to guide the caput of bone to the scapula glenoid? It is necessary to externally rotate the upper arm, which is inner turning. It is necessary to push the head backward, displacing forward. It is necessary to draw the head, which is transplanted inward into outward. However, because the coracoid process blocks the repair path, it is essential to pull it downward and then return it to the upper side. Now, if you imagine the operation you need, let's move on to reduction. Up to this point, you have learned the mechanism of occurrence and the shift. Finally, let's carry out reduction and return to the original position. We will do the cockle method, which is the reduction method of shoulder joint anterior dislocation. I could rearrange it to the original position. From here, I will explain the meaning of the procedure one by one. The patient's limb position is sitting position, upper arm mild abduction, inner rotation. First of all, it is grasping. Let the assistant fix both shoulders. The surgeon grasps the lower arm with one hand and the wrist joint with the other hand. It transfers the upper arm, which is a mild outer dislocation, in the long axis direction to the periphery. At the same time, bring the upper arm close to the side chest wall. Continue towing, rotate the upper arms externally. Keep the elbow close to the median plane so as not to loosen the toe but to slide the anterior chest wall while keeping outward rotation. When the upper arm is rotated inwards, it can be seen that the head is subjected to an external force. Lift the upper arm forward while maintaining towing and inversion. At this time, the force is applied to the head to the joint fossa, and the head fits into the joint fossa and is reduced. Finally, as a confirmation of the reduction, make the shoulder joint inward. At this time, rotate the shoulder joint inwardly. The palm is passed through the face and to come to the shoulder of the healthy side. If it has been successfully reduced, its posture can be kept comfortably and the reduction will be completed.